which kind of fibroids have impact on fertility, to learn which myomas should be removed in infertile patients, to know the outcome of patients having had myomectomy and fertility, and to approach the treatment modalities of myomectomy in case of infertility. We will say that it is, we raise more questions than answers, but we will try at the end to give a summary and maybe a small consensus tentative maybe. So first of all, which fibroids affect fertility? So if we see in the literature the impact of myomas on IVF result, you see that first of all we have decreasing between the submucous, intramural, subserous, and the control group. You see that when you get close to the cavity, you have a decreasing of the pregnancy rate. When it is subserous, it is the same as the control group. Also, it seems that the size may affect, the pregnancy rate, and that it is, well known that if you have a big fibroid, maybe you have some impact on IVF result. But also, we maybe have some effect of small intramural myomas, less than 5 centimeters, after 3 attempts of IVF-ICSI. You see this paper from Calaf, and it demonstrates that in this study, intramural fibroids significantly reduce the pregnancy rate, the ongoing pregnancy, and the live birth rate. But it is one of the studies. We will see that we have a lot of other studies. And if you try to see a lot of studies about intramural or submucous fibroids, you see that we have some study showing that there is no effect on IVF result, and also other studies say there is a lot of deleterious effect on IVF result. It is quite evident in submucous that every submucous fibroids have deleterious effect, but it is, not evident when you see the effect on intramural fibroids, as already mentioned by TC. So if you review this study for intramural fibroids, it was a meta-analysis of Klatsky. You see there is a lot of different studies, prospective, retrospective, and you see that it is controversial because some studies demonstrate that we have implantations when there is no fibroid is better, but we have even a paper demonstrating that the implantations in case of fibroid is equal to when we have no fibroid. So once again, we cannot conclude to say anything. Also, the clinical pregnancy rate and the spontaneous abortion, if you summarize all this study, you can see that it seems there is a small difference between pregnancy in case of fibroids or no fibroids, and for the spontaneous abortion, it seems that we have in this situation slight but significant difference. So, in all these studies, there is a lot of bias, mostly no adjustment for age, disparity between studies and control groups. So it's very difficult to conclude. A lot of studies have a lack of power. There is a lot of controversies, but maybe we may say that we have a slight decrease in implantation rates from 22 to 18%, an increase of spontaneous abortion rate from 8 to 15%. In case of intramural fibroids. As you see, it really is difficult to conclude anything of these studies, but it was already mentioned by the previous speaker that it is something which is really difficult and we are missing some evidence. So we may say that fibroid location followed by size are the most important factor determining the impact on fibroid and fertility. And maybe in the first approximation, we probably may say that we have to do myomectomy when it is submucous, or if we have large interstitial myomas or large fibroids, more than 4 to 5 centimeters in case of unexplained infertility. And we will see that it is probably not sufficient to say that. Now we have to speak about the kind of myomectomy, because as you know, we have laparoscopy, laparotomy, or hysteroscopic approach. How to remove myomas? As you know, that in case of 0-1 type at the figure classification and sometimes 2, it is hysteroscopy. When it is 3, 4, 5, 6, 7, and some cases of big 2 myomas, it is laparoscopic procedures who will be the preferred approach. So first of all, we have to see what is the outcome after hysteroscopic myomectomy. So if you see a quite recent Cochrane database, 2015, RCT between operative hysteroscopy versus control in patients with otherwise unexplained infertility. Only 2 studies met the criteria. 21% of pregnant without hysteroscopic myomectomy versus 39% pregnant after myomectomy, with quite a low evidence, and miscarriage very low evidence. So the conclusion of the author was a large benefit with hysteroscopy removal of submucous fibroids for improving the chance of clinical pregnancies cannot be excluded. So it is far from certain that we have once again a clear evidence, but it seems that probably it is something which could be done, that would have been done. So another study about pregnancy outcome after hysteroscopic myomectomy, 100 women, more than 1 year of infertility, the pregnancy rate not related to the number, the localization of the size of the fibroids, and abortion rate was interrelated with myomas situated in the anterior uterine wall. So the location seems to be important. And also they said in these studies that the preterm delivery was significantly influenced by myomas localized in the fondic wall. And I did not see other study about this, this notion, but it seems to be important and significantly important. So also this paper about the submucous myomas and their implication in the pregnancy rate of patients with otherwise unexplained primary infertility undergoing hysteroscopic myomectomy, and it was a randomized matched control study, so study group 100 patients, control group also 100 patients, and you see that the pregnancy rate in the control group is really lower than in the study group, and in the study group has a better possibility of becoming pregnant after myomectomy with a relative risk of 2.1. Irrespective, once again, and we speak about hysteroscopy, irrespective of the size, number, and location of the myomas in this study. Then we have to look after the outcome after laparoscopic myomectomy. What are the factors influencing myomectomy outcome? Obviously, there is a technique, how we are going to close the myometrium, and first of all, we have to discuss what route, laparoscopy or laparotomy. Clearly, it seems that we have a lot of advantages when you do laparoscopy compared to laparotomy. And we can quote, the less blood loss, less postoperative ileus, shorter hospital stay, less painkiller, faster recovery. We may say that it is quicker when you do laparotomy. It is not always the case if you have good experience. And also, it is not mentioned in this study is that it is, I think, the main advantage of the laparoscopy, that your vision is much better. And if you have a better vision, then you do a more precise surgery. And I think that it is an important parameter that we have to take into account. So is the pregnancy better? If you compare laparotomy to laparoscopy, you see we have this study. And when you see the different item, pregnancy rate, preterm delivery, vaginal delivery, in fact, there is nothing which is statistically different in this study from Zulo. So I think to demonstrate something like that, we should have a better or bigger study. Once again, it is a problem of the study concerning the myomas, is the series is rather short. But probably we may say that laparoscopy, when possible, is better. So, factor influencing outcome after myomectomy, it is the quality of the myomectomy, but also we have to note that we have potential adverse effect of myomectomy. It was already said by the first speaker that if you have to be careful when you do myomectomy, you can do worse than to do nothing, and the risk of adhesion formation, of synechia, and uterine rupture. I think it is the three main risks that you are facing when you decide to do a myomectomy, whatever the route. So postoperative adhesions, You see this study demonstrating that you seem to have less adhesions in laparoscopy than in laparotomy. At the beginning of laparoscopy, we thought that we have no risk of adhesions. In fact, we have, and we have a lot of risk of adhesions. But probably it is slightly less if you do laparoscopy than if you do laparotomy. Once again, it is a question of technique. Adhesion formation, so you see this study demonstrating that probably we may expect to have around 35% after laparoscopy, so less than laparotomy. It depends on the location. We have more likely to have adhesions if it is a posterior myomas, that it is significant. If it is intramural compared to subserous, we have more risk to have adhesion formations. And also the number and length of scars is important. And the size also, and the cutoff seems to be when you have a myoma, which is the size of a 13 pregnancy week, then if the myoma is really bigger than that, you increase your risk of adhesion formations, whatever the technique you use. So reproductive outcome after myomectomy, so we have some study. This one from Campo, 41 patients. 14 already have pregnancy, and these 14 patients, half of them have already a miscarriage. So he compared laparotomy to laparoscopy. We have identical pregnancy rate, miscarriage the same, no ectopic, no ruptures. And he demonstrated that the determining factor was the age, and it was already mentioned that if the patient is younger, it is better. The size, if the myoma is smaller, it is better. And laparoscopy is better in these studies than laparotomy. So once again, a new argument for laparoscopy. And surgery seems, in fact, to improve pregnancy rate, and depends on the age, of the size, and obviously the technique. Impact now of myomectomy on IVF result. Once again, no clear evidence. We have some papers saying that there is no evidence, so no improvement. If you do myomectomy, it is a paper of Surrey and this one of Oliveira, say, okay, no positive impact, in fact. And we have also a paper saying exactly the contrary, saying that if you do myomectomy, we have a good impact on the IVF result. So once again, no clear evidence, and it's once again an argument to tailor the surgery case by case, because every patient is different. So we arrive on some technical point, how to close the myometrium. What it is important is to obtain a perfect approximation of the myometrium. Absorbable suture seems to be the best. 2 plants, and you have seen that if we have only 1 plant, the risk of rupture is probably bigger, and we have really to do 2 plants if you have a risk to create a dead space. So it is very important not to have any dead space, because we have seen the beautiful imaging from TC where we have a big hematoma or big fluid cyst. So it means that really we have to avoid to have this kind of dead space. You may use barbed suture. That also is controversial. I like it because I think we have very good result. Some people say there is a risk of to have ileus if you have some bowel stuck on the suture. I think it is more theory than real. What we do since now many years that we just always cover the suture with interseed. So in this case, since it is absorbable suture, we never have any problem, and the scar seems to be very good. It is not the only technique that we can use. I use that technique, but you can use, of course, a lot of other techniques. What it is important is the approximation and no dead space. I think that it is the 2 most parameters that we have to consider when you do this kind of procedure. Now the risk of uterine rupture. Once again, we will see that it is rather controversial, because this theory is very bad, I would say, because it is quite a recent theory. You see 59 patients with quite a good conception rate, a good rate of miscarriage, which is 24, I would say acceptable. Half of them C-section, but uterine ruptures in 10% of cases. So it is a small theory, but really it raises some concern, because if when you do myomectomy, you are exposed to the risk of 10%, really we cannot propose to do that. So it seems that in this series, it was maybe quite old procedures and the quality of suturing was not the best. Because if you see other series, and this one is reassuring because you know the number is quite big, more than 600. Multiple myomectomy in sort of cases, intramural myomectomy, mean diameter 5 centimeters, average delay to pregnancy 14 months, but what it is important is that you see that the risk of uterine rupture in this series is very low, 0.6, and that is something which has to be considered. And if you do now see some other results in the literature, Hassan, Reich, Nezat, Ribeiro, and Dubuisson, you see that the number of deliveries is quite big, especially in the series of Dubuisson. And in all, we have only one uterine rupture, which is consistent with the previous series. It means that we have only 0.5% of risk of uterine rupture. I think that it is something now which is quite well established. You can do myomectomy by laparoscopy with a minimal risk of uterine rupture, providing that your technique is good. Now the deliveries after myomectomy, we have a comparison between patients having had myomectomy, but once again, limited series, 18 patients, compared to patients having had C-section, 72. You see that acceptance of vaginal delivery was in half of the cases in case of myomectomy, which was higher in case of C-section. And the success now of vaginal delivery, you see almost 19% of patients after myomectomy, which is better than in case of C-sections. No uterine rupture after myomectomy, and in this short series, there was some rupture after C-section 3, which is quite high. And also, which is important, no difference in the rate of postpartum hemorrhage, which was one also of the concern when you do myomectomy, is the risk of postpartum hemorrhage. So you see, this series do not demonstrate anything, but it is a short series. So to summarize, at the end of my presentation, a bit before to conclude, I will find the recommendation of the Society of Gynecologic and Obstetricians in Canada in 2015, so it is quite recent. And I think that the conclusions are quite well balanced. They say that subseral myomas have no impact on fertility, that it is quite well accepted. Intramural myomas indication is limited if cavity is not impaired. Hysteroscopic resection when submucous myoma less than 5 centimeters in diameters and more than 50% in the cavity. I think it is, if it is more than 5 centimeters, then it is a good place for the agonist. No evidence of interest of Foley catheter to reduce adhesion formations after hysteroscopic resection, but we may think that it is interesting to use either hyaluronic acid or the small balloon from Cook. I think that's something which is probably important. Embolization is not recommended in infertile patients, so maybe we can discuss that with Geddes. Laparoscopic is a better of choice, providing that the team is skilled enough, and I think that it is, of course, something which is important. And anterior incisions should be preferred to minimize the risk of postoperative adhesions. I think this is quite good guidance when you deal with myomas, but as we said, every patient is different. So I will try to give some conclusions. First of all, do we have to remove small intramural myoma and submucous fibroids prior to ART? Yes, I think, always for submucous myomas. Probably yes to intramural if they are close to the cavity, and especially if there is no other infertility factors. And we have quite a lot of patients with only nothing in the infertile workup except quite a big intramural myomas, and I think we should consider to remove it. But we can do that if there is no risk factor, if the team is trained enough, and obviously after clear information and consent. And already we have spoken today about the need to inform the patient and the choice that we have to give to the patient. In this situation, I think it is really something important. Conclusion 2, fibroids and IVF, which come first? I think that it is quite evident if you have submucous, you have to do that before IVF. If it is intramural, I think you should propose myomectomy after IVF failure, because we have no sufficient evidence to propose intramural ablations before IVF if it is not so big myomas. Laparoscopy, conclusion 3. Laparoscopy seems really now to be better than laparotomy. If possible, anterior incision, because we have less risk of adhesion formations. Be aware of the technique of suturing, we have to be acute. No dead space left, I think that it is something really important. Prevention of adhesions, of course it is a technique, but also we can add something like a yellow barrier, like intercede, like depth, whatever you want, but probably to do something for adhesion prevention in something which is good. And vaginal delivery is in fact possible, and that it is something which is important to consider. And myomectomy improve fertility. Also, we have to say that what is the delay after myomectomy to accept to have pregnancy? Classically, the delay is 6 months. I think we may reduce that now to 2 months, and we have now quite a good evidence that we have no risk of uterine rupture when you speak to the expert of the things. Hysteroscopy, if it is less than 5 centimeters in diameters. If it is more, I think you can do that in 2 times, or to give agonist. I think that it is a good indication for agonist prior to do surgery. And we have to think about the prevention of synechia, and it has already been done by the previous speaker, so I don't want to come back about that. And in this case, we may consider that myomectomy improves fertility. And I thank you very much for your attention.
Antoine, thank you very much for this excellent presentation. I have been tweeted from questions from the floor because they have been frightened of you. But Professor Nisol has, I have a question from Australia and Greece, one from Romania, one from Albania, and one from Japan. But the first question comes from Professor Nisol, a very polite question.
Yes, always polite. So thank you very much, Antoine, for your beautiful presentation. And concerning the risk of uterine rupture, do you think that the delay between the surgery, myomectomy or cesarean section, is important to avoid the risk of uterine rupture?
I don't think really, because we know that the healing process is quite quick. And if you do second loop laparoscopy some months after, you cannot see anything. So I think probably there is no big difference. It is why we may accept the pregnancy quite quickly, because as you know, before that the uterine is growing up, there is some months. So it means that the tension and the scar will not start before 6 or months of the pregnancy. It is why we do not consider that we have to oblige the patient to wait more than 2-3 months after myomectomy.
Okay. Thank you, Antoine. Did he answer your question? Say yes.
Not yet.
Not yet.
Not completely, yes.
Not completely.
If I can make a comment. No. In fact, previously, after cesarean section, a long time ago, we said to the patient 1 year, 2 years before the next pregnancy, and now for sure we decrease the delay. But for myomectomy, even the scar seems to be good. I think that we must be careful, and in my department we are waiting 6 months, but I don't know what is the opinion of the floor.
Yeah, the question is, we know that we have some sclerotic tissue, the scar. I'm not sure it will change anything if we wait a long time, apparently. But okay. It is, we have no clear evidence.
Okay.
Agree with waiting 6 months? Hands up. The ayes have it. Thank you. Please, when you address the question, please state your name, your rank, your serial number, and credit card number with PIN number. Yes, sir. Your name is?
Dr. Elie Snifer from Lebanon. First thing about the delay, 6 months or 3 months. Sometimes we are obliged when we are facing a woman 41 years or 42 years, it's not acceptable to wait 6 months. I think it's better to wait 2 to 3 months before going to IVF. But it's not my question. You mentioned here that the best technique is laparoscopy, myomectomy, and we are facing the problem of morcellation, especially in study making in United States. What do you think about the risk of morcellation and between the DLAM, sarcoma, myoma? Because I think doing laparoscopy without morcellation, it's very difficult.
Yes, I imply, of course, morcellation, but as you know, the speaker after me will speak extensively about morcellation, so I think we have to keep that for the next speaker. But it is an issue, of course, you're right.
Dr. Venetis, do you have a question? You don't want to go to the toilet? No? Okay. Yes, sir. Yes, sir. Who are you?
Shadi Yazbek from Paris. Thank you very much for this nice presentation. I would like to know what is your opinion about the cutoffs in laparoscopy, myomectomy, in both size and number of myomas. Do you have cutoffs for doing laparoscopic myomectomy?
That it is obviously a very good question, because classically we say no more than 3 myomas. In fact, now that we do laparoscopy very easily, we can remove a lot, in fact, by laparoscopy. After that, it's a question of time. But I think the most important factors, and TC mentioned that, it is the length of the scar, and probably if you have too many myomas and small myomas, 1 centimeter, 2 centimeters, we should consider to leave it. But if it is, very frequently I remove 4 or 5 myomas when it's 4 or 5 centimeters, and I think that it is okay by laparoscopy. And after that, the question also is the hemostasis, but it is the same in laparotomy. So really today we don't see good evidence between laparoscopy and laparotomy. We consider more or less indication are the same. But if you have really multiple myomectomy, if you have to remove, say, 15, then we have to do that by laparotomy, of course.
Do you see a role of robotic surgery in this kind of indications?
Really, I don't think so. Robots is a fantastic tool, but in this situation, I think robots is great if you do tubal anastomosis, or sometimes maybe in deep endometriosis, but for myomas, it is not a really difficult technique, and I'm not sure that the robot will help you. It will lengthen the procedures a little, much longer, and I'm not sure, but nobody knows today. Maybe in the future.
Chairman's prerogative. Who has done myomectomy with robotic surgery? Thank you. Thank you. Tom, you're second after this gentleman here, right? Yes, sir. Who are you?
Yeah, from Belgium, Dr. Clodo from Belgium.
We have 15 minutes more of questions, so we can speak a little more slowly. I won't shout at you so much.
I'm coming back with 2 questions. The first one is the delay is coming down from 1 year to 6 months, perhaps 3 months. I suppose you are talking about the spontaneous risk of rupture during the pregnancy. But this delay concerns about the way of delivery. If it's too low, let's say 3 or 6 months, would you prefer a cesarean section at the end of the pregnancy? I'm not regarding the spontaneous risk of rupture. And my second question is about your technique of barbed suture for myomectomy. Do you do that in 2 layers with the same strength?
Okay, for the first question, I think in my experience, which is obviously limited, I made no difference if we get the conception 3 or 6 months after the myomectomy, in my experience, but I'm not sure to be right. And concerning the barbed suture, it is only for the second layer. For the first layer, I will do with Dexon or whatever, but not with the barbed sutures. It is just for the, I will say, the final stage of the suture, the second plan.
Thanks.
Professor Ind from London, UK.
Yeah, Tom Ind from London. Thank you for that talk. I have to say, I think I'm going to claim double CME points. It was a brilliant evidence-based talk, and thank you for it. I'm very privileged to have been here. I want to just ask a question, and I disagree with you about robots, but it's for another time. You gave an evidence-based talk. Now, I'm an insulin-dependent diabetic, And my doctor has put me on a drug called ramipril because there's clear evidence from randomized controlled trials that I have less chance of diabetic-induced renal failure if I'm on it. If he didn't, he would be negligent. Now, you've just shown us clear evidence from randomized controlled studies that a laparoscopic myomectomy has better outcomes than an open myomectomy. Why is it acceptable to continue doing open myomectomies as a routine in this situation? If that evidence demonstrates we should be doing it laparoscopically, we shouldn't be allowing people to do it open.
You mean by laparotomy?
Yeah.
Yeah, I agree, but so, if you see the impact of laparoscopy and the prevalence of laparoscopy in the old techniques in gynecology in Europe, I will say, it is quite few. Look for hysterectomy by laparoscopy. In France, I think it is only 15-20%. And we consider we may increase, and we should not see anymore hysterectomy by laparotomy, but still it is the measure. But I totally agree with you.
Okay, you've just answered a robot question, because there are lots of studies that demonstrate that a laparoscopic approach is utilized more in institutions that have a robot, and you're doing less open procedures if you've got a robot at hand. That's the answer to the robot question.
Yeah, but maybe, you agree?
I've just for the public, the audience, Tom, I've just blogged every gynecologist in London with your remarks. So you'll either be fated with a bunch of flowers or you'll be maimed and damaged. Yes, sir. Name, rank, serial number.
I'm Dr. Ashwath from India. My question is...
India is a big country. Which part?
In Kerala. That's the southernmost part of India.
Where the women dominate the world. Thank you.
When you do myomectomies, many times, one thing, first question is that you told to do preferably do an anterior incision. But many times when as a laparoscopic surgeon, we try to put incision where if it's a posterior myoma, you put the incision on the posterior side over the myoma and take the myoma. My question is different. Is there any difference when you open the cavity, after opening the endometrial cavity, while doing surgery, it has any influence on the fertility and pregnancy? If you're opening, that's the question is that if you're opening, if you want to delay the pregnancy, or opening the cavity, is there any problem while doing myomectomy? We have to be careful while opening the endometrial cavity, has any influence?
Yes. I think there is some influence, you're right. I have no data about that. I think what we should say that we have to have a very good closures, and maybe in this time we may think about 3 layers. First of all, very close to the cavity, and then 2 layers more. So that it is my answer. I don't know if anybody has evidence that there is a strong influence about fertility, but probably they should have any influence, because if you don't close correctly the cavities, then we may have synechia or Asherman syndrome, even worse.
It's depending on pregnancy. If it's open, if you open the cavity has been opened, should be as any influence of delaying the pregnancy more than 2 months, or what you told 2 months?
No, there is no difference, and once again we tried not to open the cavity whenever it is possible.
By accidentally it is opened?
Yeah. So we close it, but we don't change anything after that.
Okay.
Now, TC, do you have any evidence of when you open the cavity, if there is influence in fertility result? I've not seen many papers about that. No.
Sorry, sir. No, there's one before you. Good. And then there's another gentleman.
Thank you for an excellent speech. I am Dr. Chakraborty from eastern part of India. My place is Calcutta. Now, I would like to know one thing, that there are some people who are talking about the not going for any morcellation without in-bag morcellation because of the sarcoma spread and all. They are of opinion that you can use GnRH analog before going for myomectomy when the fibroid is bigger, because that will prevent the operative time and extent of incision. So what is your opinion about this?
You are certainly right concerning hysteroscopic resection, but if you now consider by laparoscopy or laparotomy, the dissection plan are very bad when you put agonist before. So it's why we do not recommend to use agonist prior to laparoscopic myomectomy. Really.
Okay, thank you.
Okay, our friend from Romania?
Yes, Romania first, then you, sir. Yes, sir.
Thank you.
A short
sir.
question.
Yes.
One question.
One question. Do you use ever the uterine artery ligation before a big myomectomy? I have more than 20 years experience in this. In general, when I'm doing intramural big myoma, I'm ligating in the first step the uterine artery with a short-term suture, and it improves the bleeding between. And as I've noticed in my experience, the results are very good. I have never uterine rupture after.
Yes, you're right. I think in selected cases is very good, the tool, even if we have to know that when you see in the literature there is no statistical improvement in the bleeding. But I agree with you. If you have a big myomas, it's a good thing to start with occluding temporarily the uterine artery. I agree with you. Yes, good technique.
Okay, thank you.
Thank you.
Yes, sir.
I'm Arun Barua from northeastern part of India. My question to you is, considering the uterine muscular anatomy, putting a longitudinal incision versus a transverse incision, which one is preferable for final outcome of myomectomy? That
Yes,
is number one.
Yeah.
And number two, okay, sir, you can.
No, go.
And the next question is, to improve the adhesion, to prevent adhesions, what is your recommendation? Because there is no clear-cut evidence that this one particular step promotes less adhesion than the other.
Okay, so for technical reason by laparoscopy, I prefer to have oblique incisions or transversal one, because when it is longitudinal, it is a little more tricky to suturing. So it is the first thing, and usually if you have myoma, you can choose what you want to do. And so I think that it is a technical reason. Now considering the second question about the adhesions. Adhesions, you know, as it said, the first important thing is the technique, then it is the technique, and lastly the technique, that it is what we have to say. I think interseed is not bad, especially when you use barbed suture, so we are sure to cover, you know, every spike that we may have on your scar, which is probably more theory than real, but nevertheless I will do that. We can use other means like ADEPT, which is probably, you know, less expensive. I think some flotation is good. More and more we are using also hyaluronic acid gel, which is not bad. We have no evidence that there is something which is superior. Probably nothing is perfect, but it is better to do something than nothing, probably.
Thank you, sir.
Yes, sir.
Yes, sir.
Thank you very much for your presentation. About the morcellation, we use the morcellation into the endobag in laparoscopy. About the myomectomy, I start with operative hysteroscopy from 1993 with a cooperation with Médecins Sans Vacances from Belgium. And my teacher, it was Joris de Meer. And about the size of the myoma, Joris de Meer said, it's one myoma, he can be removed by all the gynecologists who know hysteroscopy. The second category is for gynecologists with experience. And the third, only who have the courage. About my experience, I remove myoma more 5 centimeters, 6, 7, even 8. And about the number, I remember a case with, I don't remember exactly, 11 or 12 myoma, submucous myoma, between 25 and 10 millimeters. I remove all of them in one time, and after 4 months, the lady was pregnant. About the big myoma, it's not possible every time to remove in one step. And usually, I remove maybe 3/4 from the volume and make another hysteroscopy after 1 or 2 months. And usually can remove everything. And for the rest till the pregnancy,
sorry.
I use 3 months.
No, you have to ask the question. Then
Yes.
afterwards, the coffee. Right, okay. So you have to ask the question.
Okay, I finished. Thank you.
Thank you very much. Thank you. You raised very important points. And it's important to hear that. Antoine,
if
comment?
I may say a small comment, you are really an expert in hysteroscopy. Congratulations. For myself, I'm not able to remove as many myomas submucous as you do. Probably I will say be careful when doing that, because if you do that, the risk of complication is quite high. But if you are an expert, maybe why not? But in my hands, I will not do that, really. I'm not able to do that, I have to say frankly.
Thank you very much, delegates, for a very highly interactive session with an exchange of information. We are 1 minute ahead of time. That lady is waving to me saying, let's get the next speaker on.